Everybody, and great to see so many people online. And obviously we're recording so that you can refer back to it afterwards, but also it'll be available. So we're going to hopefully this is a session where we'll give you plenty of opportunities to ask questions and to make inquiries, to find out a bit more about our thinking. You'll hear from me about the Core 20+5 from the sort of NHS England side, and then we'll go to our IHI colleagues, Lindsay Martin and Selena Stephen, to talk about the IHI side of things, and then we'll have a questions and answers session. What I would like to say is that this whole piece of work, this whole collaborative, is about learning and sort of, understanding challenges and stumbling blocks, and kind of trying to learn from you and learn from the work and how we can kind of build solutions. So it's a very sort of iterative process, but also very heavily supported with lots of well-established techniques in quality improvement and coaching and everything. And we're so delighted to have our IHI colleagues working with us on this. So we'll, and Andrew has very helpfully posted up the link to the portal to express your interests in the programme. So if we can move. You're not going to be able to hear. Great, thank you. So I'm sure a lot of you are familiar with this infographic now, and if you're not, I guess we haven't done our jobs very well. But this is the Core 20+5 programme, and so I'll just briefly talk you through the cohorts of populations that we're looking at, and also the areas of health inequalities that we're trying to improve. So our target population are the populations we're looking at are Core 20 and plus. So the Core 20 is 20% of the most deprived population in England, defined at a national level, and this is defined using the index of multiple deprivation. You'll see straight away that the index of multiple deprivation covers many more dimensions of healthcare, of inequalities than healthcare. So we've included in there is crime and education and housing. So this is really just to reflect how important the social determinants of health are, but we are focusing very much on the healthcare end of inequalities, and really trying to improve things from there. And the other thing I just would like to mention about this is it's the Core 20 defined at the national level. So obviously within each ICS, the percentage of the Core 20 population is variable, and some groups will have many more. So it's not defined at an ICS level. And the plus group is also locally, is in the opposite way, locally defined at an ICS level. And this includes all populations who are at risk of or already experiencing healthcare inequalities. So we've included in here inclusion health groups, vulnerable migrants, people living with learning disability, maybe gender. So what I'm trying to get across here is that this group is actually tailored to the local population. So we aren't very strict about what people are included in this group. However, we do want to make sure that those with lesser heard voices are included. So that's how we would like to support you with identifying these populations. And then the 5 key clinical areas of health inequalities that we are addressing are listed across the bottom. And these are areas where the gap between the most and least deprived populations in terms of mortality and global burden of disease. So this data is from the Lancet Global Burden of Disease study, and these are the areas where the gap is the largest. So in respiratory disease, cancer, and cardiovascular disease, we know that there's about a 20-year difference in life expectancy between most and least deprived communities. We've also included maternity care, and this is because of the harrowing statistics that we know it is more likely for a Black or minority ethnic woman to die during pregnancy and childbirth in this country. And in fact, she's 4 or 5 times more likely to die compared to a white woman. So this is an absolute priority for us to really address those harrowing statistics. And similarly with severe mental illness, the gap in life expectancy and quality of life and burden of disease is extremely large. And so what we would like to do is to increase uptake of the annual health checks to address the comorbidities that people living with severe mental illness suffer from, and try and drive up survival and morbidity that way. We've also included smoking cessation as a distinct area of intervention, because we know, first of all, that it has an impact across all 5 of the clinical areas I mentioned, but also we know that it's intricately linked with inequality and deprivation. So they're the kind of core founding principles of Core 20 plus 5. And Core 20 plus 5, as you all know, are the agreed national strategic priorities for addressing healthcare inequalities in the NHS in England. And so we in the Health Inequalities team are held to account in terms of the goals and trajectories, but we recognise that to actually improve healthcare inequalities, there's a very multi-system collaborative approach needed. I'm delighted to direct you to this NICE resources if you haven't already seen it. So NICE have, we were working with NICE for a long time trying to sort of agree on a guideline for health inequalities. We sort of felt like, wouldn't it be great if we had a guideline, a kind of an instruction book on what to do? But actually every time we tried to write it, it went out of date even before we were finished. So what they've done now is they've developed a portal, a website where everything that's related to healthcare inequalities is mapped onto the same page. And I would really highly recommend it. It's a really great resource, and it's designed to be used at ICS level. So it's really full of case studies, improvement methods, and ways of measuring little projects, but also how to identify the populations and then the different recommendations that can be used. And I think it really underpins the vision of the Healthcare Inequalities Improvement Programme. So that is to deliver exceptional quality healthcare for all through equitable access, excellent experience, and optimal outcomes. And we know that access is an issue and has been for decades in the NHS, inequity of access. And so this is one of our really strong focuses, but the experience element is very important as well, because we know that if people have a poor experience, they're unlikely to return, and they're also unlikely to recommend health interventions to their friends and family. And then we hope that addressing access and experience will lead to optimal outcomes for all in the future, in the years to come. And could I go to the next slide, please? So our support offering is kind of constantly in development and constantly evolving, and this Core 20 Plus collaborative is very much part of that. And I think, underpinned by the NICE resources I just talked about. And I think the Core 20 Plus collaboratives will hopefully work very closely with the Core 20 Plus ambassadors, which are over 100 clinicians and professionals who are really dedicated to addressing health inequalities at ICS level, and the Connectors programme, which are community leaders that are championed. And as I said, there's a whole suite of tools and dashboards that are available on our futures page as well. So I'll go to the next slide. Thank you. So as you know, we'll be hearing from the IHI colleagues, and the idea, as I mentioned at the start of this talk, is that we will actually all learn, and we'll learn how to accelerate improvement of healthcare inequalities. We know that we have loads of data, loads of reports, and loads of enthusiasm to actually address healthcare inequalities. And what we want to do now is really do that in practice, really implement Core 20 plus 5 and gather the learning from that in a supported way. So you're all here today to hear about our shortlisting process for the 7 pilot sites, 1 site per region. And NHS England will be providing 45,000 per site, and about 35,000 will be used to commission the IHI to offer the support package that you'll hear about in a few minutes. And so the monies will be transferred through NHS England through the regional and ICS structures. And the advert is currently online. Next slide, thank you. And so I think a lot of you have already seen these slides, but what we want to do is we've got two tracks for this work. So track one is really setting up oversight groups and steering groups, or a steering group, to sort of support that learning that I mentioned, and to help with the problem solving and solutions making at a national level. And so we're setting up the track one steering groups at the moment, and track two is where we have all your input into the ICSs. What I will say is that we're starting with 7 ICSs, 1 ICS per region, and we really want to understand how to and learn how to spread the change and spread the improvement. And next slide, thank you. And the time frame, so it will be a year from the launch of the program, and with learning events as we go. Thank you. And then this is more detail that we can share with you in the slides about the ICS sites. And the timeline again, which is very similar. Thank you. So as you know, we're open for applications at the moment, and we'll be able to answer some questions. If you'd like to put questions in the chat, we can start addressing them as we go, and then we'll also have a question and answer session afterwards. And next slide, thank you. Great. So I'm going to hand over to my IHI colleagues to describe their role in this work. Thank you very much.
Aoife, thank you so much. And thank you all, 80 some of you, for joining us today this lunchtime. What a wonderful turnout. Thank you, every single one of you, for making the time to come along today. We are delighted to see you. My name's Selina Stephen. I'm a director with the Institute for Healthcare Improvement, and I'm very pleased to be joined here today by some of our IHI team. We've got Shubi Tandon online all the way over from Boston. She got off early this morning. She's our fantastic project manager who will be running this with us. We've got Jonathan McLennan here, who's one of our faculty who will be working with us. We're extremely lucky to have him. He's very, very experienced with running collaboratives. And then, of course, last but not least, the wonderful Lindsay Martin, who is our senior program strategic advisor for this work. And she's been working with Aoife and her team over the past number of months on developing this partnership and this program, so to get us where we are here today. So welcome from all of us here at IHI, and like I say, thank you for joining us. So I'm going to start off a little bit before I hand over to Lindsay for the important details, but I thought it might be useful to give you a bit of a summary of who is IHI, how are we here, and how did we end up working with you guys on this incredibly important piece of work. So IHI, it's a global organization. We're not for profit, the Institute for Healthcare Improvement, and we work to sustain better outcomes in health and healthcare across the world. We've been around since 1991, when the Institute was founded by Donald Berwick. Some of you may have heard of him. He's known as the grandfather of improvement science these days, quality improvement. He wanted to explore the potential for applying quality improvement methodology to healthcare. That was back in 1991, and he's done an amazing work setting up IHI. Since then, we've grown to be a global organization. We have our headquarters based in Boston, but we've got teams around the world in almost every region now. We've got some registered offices, and then we've got remote working teams across the globe. So if I could have the next slide, that would be smashing. Thank you. IHI's strategy at the moment is focused on 3 things: equity, safety and effectiveness, and system resilience. And clearly equity is our focus here today. So IHI is looking to improve health equity everywhere across the world. We do this by working with people to develop a culture of equity across the range, with individuals, with organizations, with systems, and with communities, with the one core driving aim to close the equity gap in healthcare. So could I have the next slide, please? Thank you so much. At the last count, IHI is working with 42 countries across the globe. And we work with 17 strategic partners, and these are generally large health systems based in various different places around the world, some of them in Europe, some of them in America, some of them in Australia, Africa, and in South America. And every day we're aiming to improve our reach across the world further and further. Through the work with strategic partners, through smaller partner organizations, but also through our open school. Some of you may have come across our open school, which is online learning around the quality improvement methodologies and so on. And we have delivered over 7 million open school courses have been completed. And a little closer to home, for those of us, well, we're all, apart from Shubi, calling in from the Europe region. So we have a lot of work going on in Europe, and this is just a bit of a snapshot to give you the reach of the kind of stuff that we're doing. But just many of these names here on this slide will be familiar to you. So we're working across Europe on all sorts of wonderful different projects, all at different stages. Some of them are multi-year partnerships, so we've been working with people for 3 or 4 years. Some of them are just starting off just now with it, like this piece of work here. And some of them are project-based, and some of them are around building capability and capacity for people to do the improvement work. So that's our current and recent Europe work. So that was just a whistle-stop tour of IHI. And at this moment, I'm going to hand over to Lindsay, who's going to be able to give you some more detail on the program that we're working with you for today. So Lindsay, it's all yours.
Great. Hi, everybody. We are really excited to be talking about this with you, and we're trying to do a bit, as Selena said, a bit of a speed tour so that you have time to ask the questions that you want and we can answer as best we can. So the idea of this program is we're looking for ICSs who are really excited to do some in-depth, all teach, all learn, both application of what we know, but prototyping in a broader way. So how are we thinking about reaching across disciplines within your location to help reduce healthcare inequalities? And a fundamental part of that will be sharing progress and challenges with the other selected sites, and then harvesting that to be able to share nationally, both things that we know are working and things that we learn aren't working, both of which we'll find out. So we're looking for places that have relationships developed or in progress with a variety of disciplines, and we want to emphasize that. So you don't have to have everything fully set, but the real will and desire to be reaching across pharmacy or dentistry, primary care, the voluntary sector, reach you may have with government officials. These are all things we're really interested in learning about as you consider if this is right for you. And what is probably core and underlying to everything is a commitment to designing and working across the system. So really seeing what that full system is and thinking about that integration. And fundamental to that will be a strong commitment to co-production. So we know none of this works in the way we want it to work, really reaching into the populations that we want, both in the plus populations and in the core 20, without a really strong focus on co-production. So that will be key to everything that we're doing, and we look forward to hearing about that from you. So through this accelerator sites, the goal is defined, right? We plan to use quality improvement and system design to reduce inequities in healthcare, and we've set that. We're fully committed to it. We're really excited to working on it with you. Our plan will be to do this through an improvement methodology and real system design, where we're testing and iterating rapidly, learning together, and then sharing that again across the country and with each other. We'll be doing a lot of work to be able to link sites to each other, but also where we notice that there's challenges that everybody perhaps is seeing, or there's core themes that are coming up, we'll be able to bring in faculty from throughout the country and then throughout the world to be able to help determine how to break those barriers, how to take challenges that feel like they've been in place forever and move past them. So again, as I said, we'll be focusing through models of co-production. We'll be really having strong reach into the communities. We'll focus on core concepts of basic improvement science, implementation, spread, when to scale, and then we'll be pulling that together to distribute further out to the country as a whole. We can move to the next slide, please. So let me give you a quick high-level view of how this will work. We're in this phase where we're looking for the 7 teams who will be selected as accelerator sites. There'll be a bit of pre-work to get your site thinking about what your team looks like, who's going to be in which components, and then we'll start that work very actively. We're really trying to hold to strict timelines here, so we'll start that work very actively through virtual connections, connecting with the core team and connecting with each other. In February, we will have a 1-day in-person learning event. So we'll come together to both work on new concepts and to hear from you. So everything will be both, again, all teach, all learn, going back and forth. What are the areas we need to focus on? In between each learning session, again, all 3 planning to be in person, February, June, and October. We'll be running ongoing virtual workshops, one-to-one conversations, connections with faculty, connections with other sites. We'll be working on site visits, and that will run the full time together. We will obviously at the end of our time have some celebration and progress of what we've done. We'll disseminate to the wider community, and there has been a lot of work, and actually a lot of work for the last several months to think about what already exists across the country and be able to harness and share out. So that will be happening on an ongoing basis. And we will most definitely be sharing across ICS boundaries. If we move through one more, we wanted to just be really transparent and upfront about what we're looking for and what we think will make some for good criteria for selection. So you'll have noticed that there are a few key questions in the process through which you've already gone through. We're looking at the starting point name. We want to know, where are you right now? How does this approach really align with what you're currently doing, what your current focus on healthcare inequalities might be? And not, again, as Aoife mentioned, not solely health inequalities. We know that exists. We believe that's really important, and we're focused on healthcare inequalities in this program. And is there some start of an alignment between the intention of this and the work you've been doing? We'll look at the local implementation question, thinking about your starting point. Are you thinking about maybe deep testing in one area and how you're going to learn and spread across locally? Are you able to leverage kind of current work in a population or a clinical area or reach into a broader community? We'll again think a lot about co-production, how you currently do it, where you've done it, what you think might be successful. For partnerships and teams, the same. Do you have deep partnerships anywhere, or do you have broad partnerships? Have you really started to think about where the relationships in your local area would be most beneficial? And that's all different kinds of relationships. And then challenges, what do you think is at least one limitation or an opportunity for an advancement, or something that you've said, we've tried to crack this nut a bunch and we're stuck, and we all feel that way, but we just want to hear about it. And so to be really clear, when you look at the key features, we're not looking for sites who have completed all of these, who have the perfect answers to every question. We're really looking for exploration and thought and excitement and will. A lot focused on that. So please don't feel like you need the perfect answer to every bullet point, but rather that the intention of the question area is something that you're excited about, you've started to think about, you may have some relationships. And again, our goal over the next year is to deepen and explore all of that together, and then to accelerate it by learning at 7 sites instead of just 1 locally, and then share that nationally. And I think, Rhiannon, that is, if we open for questions. 2 minutes under, so hopefully.
Thank you very much, Lindsay. And Selena, that was really great. And as I said, we're so delighted to have your positivity and expertise in improvement methodologies. And I've been trying to answer a few of the questions in the chat, and I can see that there are a lot of sort of questions around the practicalities. Like, so perhaps first of all, if we just talk about the practicalities of the application, we're looking for you to sort of send in a summary of your work at the moment, or work that you would like to do with this project. But this can change and flex over the time as I said, this is a sort of a learning opportunity. So identifying what to prioritize, identifying what populations to support and how to support them, and how to do that really collaborative co-production approach, as Lindsay said, is really key. So what we're really looking for is enthusiasm, commitment, open mindset to working together, and a positive approach, I guess. We're not looking for people who've like solved all. I mean, we are looking for people who've got the answers, because we want to learn, but we're also looking for people who are trying and are finding that they're meeting hurdles or stumbling blocks, and we'd really like to sort of get a mixture. And I really feel like the 7 ICSs will learn from each other. So I think there will be a lot of peer learning as well. And then in terms of the project, just in terms of the content that people are actually kind of submitting, it's just 1,500 words for the whole thing. So we're trying to look for sort of a real overview of all those things I mentioned. And we recognize that, we're not going to be able to sort of sign off Core 20+5 and all of the 5 clinical areas and smoking cessation as well, and get that all solved and parceled up nicely. So part of this exercise is being really practical, being really pragmatic, and supporting you to sort of prioritize and manage chunks of the work. And so sending in ideas on parts of Core 20+5 would be really, really great. But what we are actually trying to achieve is the whole of Core 20+5. And so sorry if that's sort of vague or unclear, but I guess what I'm trying to say is, we're really welcoming people who are going to roll up their sleeves and really get stuck in. Does anybody have any questions that we haven't addressed, or does anyone want to add anything to that? Rachel.
Hi, thank you very much. I did put a couple of questions in the chat. I suppose I'd really like to understand sort of the readiness that you'd be expecting in an integrated care system. And I know some of it has been really helpfully described in terms of connections with the voluntary sector and sort of an approach to co-production. But it'd be really good to understand that sort of, ideally, are you looking to work with those ICSs who've already made quite a significant amount of headway, got strategies, got a real clear approach, and it's learning from them to then inform future? Or are you willing to work with maybe ICSs who are less progressed? And that sort of leads on to the sort of second part in the question, which is, what is then the commitment from the ICS to really know that we're sort of putting as much sort of match support that we need to, because obviously the funding isn't necessarily to fund the ICS significantly. It's a small amount of money within the ICS itself to own. So it'd be really, really helpful to understand that sort of expectation to make this amazing programme fly.
Thank you, Rachel. I'll invite colleagues to come in on that, but just while they're gathering their thoughts. So in terms of your first question, so I agree with you, and the maturity of ICS is understandably not quite there in a lot of areas, and actually maybe in most areas. But so we're not kind of going to be really strict about we need a very mature health inequalities approach that's already embedded and everything. What we do ask for, though, is a commitment to healthcare inequalities, because I know some ICSs are less clear on whose responsibility health inequalities are and things like that. So that won't be helpful, I'm afraid. But we are really keen to work with keen and enthusiastic ICSs where they may not have made much progress in terms of the national strategic priorities, but there's a willingness to really try, and especially in overcoming barriers, engaging with the various partners across the system, or in doing a very collaborative co-production approach. That's kind of what we're hoping to help with. So that's definitely, we're looking for a sort of a mixture. So we're looking for some people we can learn from where they've really nailed it, and then others where we feel we can actually help and contribute. So that would be my answer to your first part of the question. And then the second part of the question, in terms of what do ICSs have to contribute themselves, I think that is reflective of another question earlier on, where I was saying that I think with this work, we know ICSs are under immense pressure, and this is a relatively small project. So if it can complement or supplement existing work around healthcare inequalities, I think that would give it more sustainability, but also more traction locally. And so I don't think there's enough resource in this to sort of create a new role for somebody, or that. And we're not asking ICSs to sort of contribute a whole person to sort of taking on this project, because we know that's unreasonable. Would any of my colleagues like to come in? Andrew, I see you've got your hand up.
Oh yes, hello. Hi, yeah, Andrew Fenton with SCW, and we're supporting the programme at this stage. So I think there's always that question, isn't there, about with these kind of accelerated sort of pioneer type programmes, whether or not you're looking for those that are already well advanced, or those that may be a bit further in sort of at an earlier stage of development. And I think we've had that partly with the Connector programme that we're working on. But I think what's crucial here is that the seven sites, the 7 programmes, and that the aim is that it is one per region, so there's a good geographic distribution across the country. Is that very much is that they both benefit individually from the experience, but crucially, of course, they're there to help support the learning, the sharing of that learning across the whole of their region, and indeed nationally. So I suppose that's probably a crucial thing, is that potential for an area, for a site to really experience that accelerated approach to Core 20+5, but equally to have a real impact on learning and sharing across the rest of the country. And there was an important question, I think, which came up about from Armina, about whether or not it could be a pilot in one place within an ICS, and that's something that the programmes team has touched on. It might be worth Aoife or Lindsay commenting on that. My understanding is that this needs to be a kind of system-wide approach. There's something about ICSs taking a systematic and system-wide approach to Core 20+5. Inevitably, I'm sure there's the scope for some level of place-based focus, but I'm not sure it can be solely a place-based pilot, or a specific, solely a very specific element of Core 20+5. But Aoife, you might want to clarify that issue.
Thank you, Andrew. Yeah, I agree. I think, a place, while we want to be pragmatic, a good example would be a place-based project that you plan to sort of spread across the whole ICS, or, plans on how to amplify that across all of Core 20+5 and spread the learning. But what we're really looking for is an ICS level system approach. So thank you for clarifying that. That's really helpful. I'm sorry, I skipped you, Alexandra. I'll come to you now. Thank you.
Hi, thank you. Actually, just builds on that discussion just now and some of the stuff in the chat about something being across the ICS, and if what you're looking for is working on Core 20 plus all those 5 clinical areas and smoking cessation and lipid management and all the other things that have been added, that is an absolutely ginormous bit of work and would involve hundreds of people almost. And I was glad I came along to this. My understanding was that you might have been able to pick within the Core 20+5 a focus on the Core 20 population in this particular area, or on a particular plus group, or just a maternity. Because I can't quite understand how, if it's meant to be across the whole ICS and or across all of the 5 priority clinical areas, that's huge. And it feels to me like it'll become a bit unwieldy, and I just can't really get my head around that. And it's only £10,000 for the ICS to do anything with.
Yeah, you're absolutely right. So I think, what we're trying to aim for is an ICS level approach, but, a sort of practical, real life implementation of Core 20+5, which won't be that everything is sorted and fixed. These are decades age-old problems across multiple systems and specialties. So I think a really practical approach may be about focusing on severe mental illness, for example, in an ICS, and gathering the learnings through the health inequalities leads, and thinking about how some of the same learning and doing could be applied to different areas of Core 20+5. I think some of the prioritization work is exactly what we're hoping to support the ICSs with, so tapping into the national data and then the IHI expertise around sort of population segmenting and that. So trying to actually do it rather than try and take on too much and not get anywhere. I think, if we think back to the core principles of Core 20+5, it's all about focus, traction and impact, so really focusing efforts and actually making a tangible difference rather than sort of trying to change all of health inequalities all at one moment. And at an ICS level, I agree with you. It's not possible to sort of do 5 different disciplines and smoking cessation and lipid management and inclusion health and everything all at once. So the kind of like prioritization and planning is very much part of the support offer. Lindsay, I wonder, did you want to come in on that? Thank you.
Sure, I'd be happy to. I would say, and while we know that everything's not going to be solved within 1 year's time, or we likely all would have done it already, right? We know this is a really difficult and complex and large problem, and the idea is to be able to learn from each other, and work differently. So to be able to think about who is around in the environment and the community that we might be able to leverage in different ways, and where you can have leads learning in different areas, and how you can accelerate your learning versus by taking something that another ICS has done. So we will most definitely be focused on how to make change in a point and not stop there, right? And be able to then take that learning and spread, take that learning and scale, take that learning and think about how we're applying it to another group, or to be able to say, how do we pull a really strong program that we know is happening in our area that has already made progress in maternity, and help provide some support, but bring them in closer so that we're leveraging that work and moving. So it's both about what are we doing now, but how can we work differently and more broadly, and then leverage opportunity from the others who are also in the group.
Thank you very much. That's great. And Fuzia, over to you, please.
Hi. Yes. So interesting in that conversation about system-wide versus trying to achieve everything. So it's so we're involved in a piece of work at the moment, which is looking at a specific area of a population of about 120, and we've created like a core 20 plus for that population, and we're trying to what we have done, it's taken a year, so it's a year's piece of work already, to understand the core 20 plus groups and how the barriers that they face, and then applying those barriers to those other areas, so the clinical areas. So redesigning our, because all of that, maternity, mental health, that's happening across the ICS. So how do we apply a local lens to all of those areas? So we're kind of a year on that piece of work. So that is it's a very, it is about a specific area. However, it's got legs in terms of how you scale that up or apply it across the system, sort of thing. Would that be something that would be of interest, or is it absolutely focus on one thing? Because we're looking at the totality of that core 20, if you like. or core 20 plus 5 for an area, but just tackling it in a breaking it down in chunk size pieces really. So it's just trying to understand, is that still something that's worth, exploring with you guys?
Yes, I think definitely explore it. And like I said, that trying to spread the work in one area across the ICS is exactly sort of what we're looking for the learning from. And sorry.
And so that's the 45, like it's, how, and the support from the IHI, is that about advice and support around how you apply quality improvement effectively, and stuff, or is there an element that you go, actually we're really struggling with defining our outcomes that we really want from this piece of work? What is the difference we're going to make? And the IHI, we could really focus that work around a specific piece. Is that possible?
Yes, I think so. I'm going to bring Lindsay in to discuss the sort of IHI support offer, and also then Andrew to come in on that.
So let me just start by saying I think the answer is yes and both. So first and foremost, we don't know the answer fully to how to do this, right? Like, if any of us had core 20 plus 5 completely solved in our areas, we would have done it. We have people of incredible value and intention and goodwill, and who do not want healthcare inequities to stand. So we know that to be true, and we know this is an enormous piece of work. And I think why I know why I'm so excited about it is to be able to think across the whole and be able to implement in a local way. So we need to think at a system level, or we're not going to change the systems that are perpetuating the current state. So that absolute focus on system has to be there, or we will not make the differences that we need. And to be clear, we want to learn in this group of 7 to be able to apply across the country. And then even I would say outside of the country, people should be looking here to say, how do we fix this other places and other countries? And so we want to learn and try and apply very locally. We need to look at a system level to be able to break down the barriers that exist that have helped us be in the current state and that have taken decades upon decades to get there. So we need to have that level of focus. And we want to be very actively learning from each other as we go, because that helps accelerate the learning. And again, no one of us has solved this problem. So working with 7 across gives us a chance collectively to be able to make that difference in a way that we can't in an isolated way. So from the IHI side, it will be about what does the group need as a whole, but it will also be about what do you specifically need to advance your next piece of work. And so our job will be thinking about what we need to do, what we need to help you with, how we need to plan and perhaps provide skills to work across this year together and beyond, right? Thinking what comes next. We also know this isn't going to be solved in a year. And our job will be also to say, what do you specifically need? Where are you stuck? And how do we bring in, if I'm not the right person, who do I need to bring in to be able to help be the right person? And so that will be part of our role as well.
Thank you.
Thank you, Lindsay. And I'll go to you, Andrew, next, and then maybe back to Lindsay after that, just to sort of describe the more detailed program plan, if you don't mind. Thanks. Over to you, Andrew.
Yeah, well, it was just partly to build on that and to sort of refer to an important question from Steve McHugh in LLR, and I think it's been touching on some of the themes here that Rachel was discussing as well, essentially about the level of input and capacity and expectation. And clearly there is need very much for engagement and input at a system ICS level. I wonder if we can perhaps elucidate that a bit more. I think there is that concept of almost having, a team, as it were, a set of named people. It might be an existing core 20 plus board, or it might be a subgroup of that, for example. But I think there's also someone has asked about whether or not it would need a program manager, and yet probably not necessarily clearly full time, but someone who is a key point of contact, maybe an SRO and a program manager, for example, with at least some amount of time to support the coordination and engagement with participants within the system, and indeed the liaison and interaction with IHI and other colleagues. So I think there is something that might be helpful, Aoife and Lindsay, that we might be able to do to perhaps unpack that a bit more. But clearly there is going to be a need for that level of engagement. And Lindsay, I like the way you described it about being kind of a bit of both and. It needs to be a system and systematic approach across an ICS, but potentially with a deeper dive or an exemplar type focus on a number of aspects, perhaps within a place or two within the ICS. So you're not trying to boil the ocean, but equally you're not trying to take an isolated projectitis approach. I think there's that kind of balance here that needs to be struck.
Absolutely, yes, and thanks, Andrew. And I agree, we will try to address and maybe articulate better the sort of input required at an ICS level. Lindsay or Selena, did you want to add anything either based on Steve's question about the sort of detail of the IHI offer and how that would balance with the ICS resource capacity? I mean, I think, it's definitely a sort of a coaching offer, improvement methodology, training in collaboration and that.
Yeah, it will be all of that. And I know I keep saying the word and, so I apologize, but it really will be. The idea is that it will be an intensive, busy time for all of us. So there will be without a doubt, one-on-one coaching in specific areas. And again, thematically, places that we're seeing, because I don't know how to do this type of work without that. It will be faculty that are linked to IHI from within country. Obviously, I do not sound like I live in England, I suppose. So it will be faculty from outside as well. And it'll be people who have expertise in different areas, and we'll be leveraging the real expertise on the full team across both organizations as it is right now. But then our job will be shared learning, there'll be tools, there'll be application, they'll be looking at data together. It will really be an intensive one-on-one and harvesting across and then applying out. And Aoife linking to experts in country too, right, who are experts in each of the clinical areas and experts in the components that we need to be able to work at the system level. I want to add one other bit, which is to the question that was asked probably about 20 minutes ago about what level of sophistication should the ICS have to be able to apply, if I'm paraphrasing, or how far along in your journey you should be. So I would say, please do look at the questions and the kind of key areas in each of them, and know that we have not predetermined the look of the exact team that will come through, right? So we very strongly believe in those areas, and we would encourage you to, if you have expertise and you're able to build off certain programs in certain areas that already exist, please do look at that, include that information. And if you have really strong will and connections in places, and you are ready to feel like you've been waiting for this to dive in and move to the next level, please do put your information in as well, because we are looking for all different, so for geographic variety, but also variety in teams, so that we can have that accelerated learning across the 7 sites.
Wonderful, thank you very much. And I wonder if there are any more questions or any more questions we may not have addressed that came in through the chat, just please let us know. Oh, Andrew, you're on mute if you're talking.
I've just replied to a question. I hope I've described it correctly. So it's a question about the funding from Melanie Roche, and I think this is an important point. about the funding package. So the total funding includes 35k around, which is essentially intended for local ICS level commissioning of or purchase of the support from IHI. So you may have, you know, commercial or procurement questions about that, and it may need to be done at that level, potentially under, you know, single tender action, for example, but that would need to be addressed. There's also questions you just need to confirm about, you know, VAT. It may well be that this is not, it can be recoverable as VAT expenditure, for example. So there's just a few financial commercial issues that would need to be addressed. But you'd have to have that ICS level commercial relationship with IHI. And then the 10K essentially is for spending on, for example, programme resource, you know, the engagement, the programme management and resourcing that would be needed at an ICS level. So have I missed anything, Aoife or Lindsay, within that sort of summary of the sort of financial position?
No, thank you. That's good.
Thanks,
Melanie.
Thanks so much. Can I just check my understanding there? I think the 10K feels kind of more clear cut to me. I'm just sort of understand about the 35K. Say we were to be successful, so IHA give us 35K, which we then need to use to buy back support from IHA. I'm just wondering, is there an opportunity to just put out the middleman with the 35K and say, congratulations, you're on the support programme, and we just get given the 10K? I just wonder, do we need to build in that layer of buying the support package from IHA if IHA are giving us the money? Maybe I'm coming at this from a very simple. Is it possible just to say you're on the programme, and here's the 10K to go towards resource locally, rather than, you know, cutting out the quite complicated local procurement process potentially, and we just allocate a team to join the programme, if that's what it has to be spent on, you know?
Oh yeah, so the funding is coming from NHS England, and then to be used to sort of resource IHI to do this program, like improvement program, I guess. And so for this specific piece of work, that is sort of how we have to do it. That is procured through the ICS. And that, you know, you would avail of the sort of support offer package from IHI. That's the condition of the resources, yeah.
So it couldn't be that there were just 7 places funded and allocated to the. I'm just thinking it feels like it's creating quite an industry of procurement process, which feels like quite a barrier. Which
I think ideally, I think I get your point around, you know, you might have a single procurement and commission and contract with you know, IHI in this case. I think that bear in mind though, once you do that, you get to a value that then actually takes somewhat longer. So the NHS processes of authorization and procurement and tendering are, I'm afraid, somewhat more I can say this, can't I, a bit more bureaucratic than perhaps we might always like. And in fact, overall, this is felt that this would be more rapid because it's at a level, the 35K, in my understanding, is, we can obviously confirm this, but is at a level that you can do this relatively, you know, with a supportive finance director, you can get through this process relatively quickly.
Okay, thank you. And it will be for a standard kind of package of, so I know there's no such thing as a standard, because obviously all the different areas will have their own nuance, very, very quite different approaches potentially within the accelerator sites. But in terms of procuring the support from IHI, would it be a fairly standard wording of what is being procured?
Yes.
Yeah, so each support package will be tailored to the needs of each ICS, but that will be decided while the project is running. So that doesn't need to be in the procurement paperwork or anything. And I appreciate that it is cumbersome, but I think, you know, we worked with finance and the Health and Equalities Improvement team to sort of see what was the quickest and most straightforward way to mobilize the funds. And so, you know, I appreciate it's not slick, but as Andrew said, it's to try to sort of maybe open an avenue for sort of a longer, more locally ICS led way. But I totally understand what you're saying. Yeah.
No, that's
And
I
really
think it's
apologise.
worth checking with. I mean, I think the crucial thing is, I think this would not be at a scale that would necessitate essentially a competitive process, say through a framework. It's something that could, I think you'd be looking to do it through a single tender action, and I think that's the thing to check with your finance colleagues. That then can be done relatively quickly and with a standard essentially specification essentially for the commission.
Okay, that's really helpful. Thank you.
Great. And
there is a question just coming from Adwa
yes,
in BNSSG, and I think it is actually partly related to that issues about the funding availability. So there's funding available in the Health Inequalities National NHS England budget in this financial year to support to initiate and mobilise this programme. And essentially, in order to make use of that budget effectively and to get started and to start to work with IHI in this financial year, then the process has to be to this timescale, as it were, in order to launch. We've launched the expression of interest process. There's a deadline, obviously later in November, and that allows time for a fairly rapid process of confirming the selection and then moving into sort of mobilisation phase in quarter 4 in the early part of next year. But it links really to the funding cycle. That's what's kind of driving the timescales.
And also sort of prioritising of addressing healthcare inequalities, I think, despite the rest of the pressures on the system. So I think we have addressed the questions, but as we've said in the chat, and thank you, Rhiannon, for all your links and answers there. So if you can please get in touch, and we will try and really understand what the commitment joining us today. Take care. Bye.
Bye bye. Thank you all.
Thanks.
Bye.
Bye.